Now, I'd like to invite Charlotte Benson to come and talk to us about the clinical trials in the UK. Charlotte was
Thank you.
Marsden, is very well known to us. Thank you very much.
Thanks very much, Barbara. Hello, everyone. Thanks very much for asking me to come and speak today. It's a real pleasure and privilege to be invited. It's also so nice to see so many familiar faces in the audience. My talk is all about clinical trials in GIST. That's a huge subject area, so I've just decided to focus on a few important ones. I don't hope to cover all trials in GIST. But before I get started, just to tell you a little bit about me, I've been at the Marsden as a consultant since 2010 in the sarcoma unit, and did my training at the Marsden, working quite closely under my mentor, Professor Ian Judson, who I'm sure a lot of you already know. I was lucky enough to work in the phase 1 unit in 1999 and 2000, and actually that was at the time when we were really trying imatinib or STI-571 for the very first time. So I did actually get to see some of the very few early patients taking imatinib for the very first time. So I saw with my own eyes the way it totally revolutionized the treatment of GIST. Prior to imatinib, really patients had a very poor outlook indeed. And I remember how excited Ian was to see these amazing changes that happened so rapidly. So why do we need clinical trials in GIST? Imatinib still remains the most important treatment that we have. But there's a few buts. We know that the median duration of benefit in patients with metastatic GIST is 21 months. Obviously, there's a huge range there. Some patients are on imatinib for a very long period of time, but other people don't achieve so much benefit. There's other questions that we need answered. We don't know how long we should offer adjuvant imatinib, so imatinib after primary surgery for GIST. And now we've got increasing knowledge about the molecular and specific subtypes in GIST. How should we be treating those? Patients with wild-type GIST, exon 9, or even the rare D842V mutation. And then beyond imatinib in the first line, how could we improve on second and third line options? I think we'll all agree that there's plenty of room for improvement. Barbara asked me just at the beginning just to outline the different types of clinical trial, because I think the terminology is a little bit confusing. So there's 3 types of trial you might well have heard. There's phase 1, phase 2 and phase 3 trials. Now the phase 1 trials are the very early trials, and those are the first time you try a new drug in a patient. So normally a drug is developed in the lab, tested on cell lines and tissue models, and when the drug looks promising, a phase 1 trial is the first time you try it in humans. So they're very early trials, and quite often phase 1 trials you'll treat patients with a huge variety of different types of cancer. And the purpose of a phase 1 trial is to see what the side effects of the drug are like and try and assess what's the best dose to use. So usually in phase 1 trials you start at a fairly low dose and escalate the dose up, looking at the side effects and then also trying to see has there been any effect on the tumour. Once you've established the correct dose, you'd go on to a phase 2 trial, and in those trials you're really trying to focus on particular tumour groups and patients with specific cancer types. So whereas phase 1 you might have someone with breast cancer, lung cancer, sarcoma, phase 2 it's focused on particular groups of patients. So there's examples today I'm going to give you of phase 1 and phase 2 trials in GIST. The phase 3 trials are the much larger trials, and sometimes people think of them as sort of Coke versus Pepsi trials, because a phase 3 trial you're really trying to establish how does your new drug compare against the gold standard treatment. So, sometimes if there's no gold standard treatment you might compare the drug against a placebo, but if you've got 2 treatments, a new one and the gold standard, you might want to compare the 2 of them and see if you can establish which is best. Phase 3 trials are usually very large and require a large number of patients. So often they're the sort of trials that take part in collaborations with people like the EORTC, so the European groups, and also the American groups. So the trials I wanted to touch on today, these are the ones I was going to focus on. So the GRID study, which is the big phase 3 trial which is completed looking at regorafenib in GIST. The Novartis BKM study, which is a phase 1 trial that we're running at the Marsden and is also running up in Manchester. Talk a little bit about masitinib and Canola Nib, and then also talk about a study that we're starting soon at the Marsden, the RMH-MCV study, and then at the end just talk a little bit about future directions of treatment. So the GRID study, this was a phase 3 study, so it was a very large multi-centred study, so people took part in the UK, Europe and Northern America, and it was comparing regorafenib against placebo. And this just tells you a little bit about how the trial was run. So what they did was they randomised it 2 to 1, so in every 3 patients, 2 would be getting regorafenib and 1 would be getting placebo. And it's what's called a double-blind trial. So that meant the patient didn't know what they were getting, and nor did the investigator. And the reason it was against placebo is it was used in third-line GIST. And as we know, until recently, there hasn't been a standard treatment in third-line metastatic GIST. We use imatinib first line generally, and then sunitinib. So third line, there's no proven treatment, so which is why they had to compare it with placebo. In the GRID study, there was the opportunity, if you were on the placebo and it was found not to be working, you could switch over to the active drug. So patients were allowed to cross over. And this study has been fairly recently published, and a lot of patients took part. And like all these clinical trials, without the patients, there'd be nothing. So we have to be very, very thankful to you all for taking part in trials. Although it does allow people an opportunity to access drugs they wouldn't normally, we ask a lot of our patients because it often means extra visits, sometimes tumour biopsies, extra blood tests, and so that's a big ask. So as clinicians, we're extremely grateful when patients take part in trials. Now, the results of the GRID study were really exciting because they actually proved that regorafenib had a significant benefit on patients compared to placebo. So when we looked at what we call progression-free survival, which is the time before the disease starts growing, the median, which is like a type of average, was about 5 months. And you can see the range is quite good. So some patients were deriving benefit up to 9 months there, compared to placebo, where patients really progressed within a month of treatment. Those patients who were on placebo were then allowed to switch over. And that makes trying to work out about the overall survival differences quite difficult to ascertain, and that's still undergoing analysis at the moment. The side effects of regorafenib were fairly as predicted from the other trials, and I think some patients here might well be on regorafenib today. They're not negligible, but the common ones are often skin rash, diarrhea and hypertension. There weren't any surprises in the GRID study. Those were really the sort of side effects we saw. Now, I've put here no quality of life data, but I actually looked again at the paper, and they did look at patients' quality of life, but they haven't reported that yet. And it's really, really important to have quality of life data in clinical trials, because that involves, some of you may well know, filling out questionnaires, talking about your daily life and how you're functioning. And for many patients, if a drug is very toxic and giving you lots of side effects, then even if it's working, the trade-off sometimes is quite small. So it's really important when a drug company wants to get a new drug license that they include patients' quality of life. On the back of these results, Mark Lynch has very successfully taken this to the CDF, and we're now actually able to use this in third-line patients in England, so we're really, really happy about that. But what's interesting is when we talk to the Cancer Drugs Fund about new drugs, they're very interested in quality of life data. And if you don't include quality of life, you get a negative point, you get -2, I think, on your overall scoring, which just tells us how important it is. So we know really for future clinical trials how critical it is that we include that. The other thing interesting about regorafenib is they treated patients with lots of different mutational subtypes, and we don't yet know with individual types of subtypes how they all got on. I think still that's under investigation. People with the common mutations, exon 9 and exon 11, both seem to derive good benefit from it, which is really good. There's still a lot of work going on behind the scenes about the GRID study, and one really interesting thing is a new technology they're using called beaming technology. And this is really a way of trying to see if you can assess patients' mutational status by doing blood tests. So normally when we're looking at the mutational status of GIST, we have to get a tumour biopsy. If we're lucky enough to have your tissue sample from previously and there's enough sample, then we can test it in the lab. But sometimes we don't have that opportunity. And up till recently, people always thought that you couldn't isolate circulating DNA from GIST in the bloodstream, but this technology has proven to be so. So they're doing a lot of, so this involves really a simple blood test for the patient. They use these special beads and do all sorts of very fancy and complicated science, but what they've found is there's a very good correlation between the blood test and the tumour blocks. So it's about 80% correlation. So that will be very helpful for us in the future if we want to know about mutational status or possibly looking for development of resistant mutations. It might mean that we could avoid going back in and doing another tumour biopsy. So I think watch this space with beaming technology. It's not something we have access to routinely in the clinic, but I think it's going to be incorporated a lot into further clinical trials. So moving on to the Novartis study. So this is a phase 1 study, and it's a study that we're running at the Marsden and also up in Manchester. And this is it's a phase 1, so it's an early study, it's a dose-finding study. And it's an interesting study because it's actually looking at imatinib in combination with another drug. Like regorafenib, it's used in the 3rd line, so when patients have already had imatinib and sunitinib. And it's looking at combining imatinib with what's called a PI3 kinase inhibitor. And the idea behind it is to try and overcome resistance to imatinib by using this drug, which is called BKM120. So when they're early drugs, they don't get given names, they just give them this very strange sort of code names. And in vitro data, so data when they're looking on cell lines, which I think Mark's going to be talking about later, shows that this combination works in both patients with imatinib sensitive GIST, but also resistant. So that's potentially a very, very interesting area. So the way this study has been running is there's been 2 phases. So, and it's a competitive entry study, so we're taking part, but also with America. And we've been through the dose escalation phase, so we've been slowly winding the dose up, and we feel like we've reached the correct dose for BKM at 80 milligrams. So we're now on the 2nd phase of it, which is looking at a larger number of patients taking this combination, and we're involving what's called pharmacokinetics. Because what you want to know is when you're testing a new drug in combination with an old drug, is there any interaction between the 2 of them? Sometimes when you take 2 drugs together, you can cause, say, the imatinib levels to go lower, which you wouldn't want to do. So taking part in this study, patients have to have quite regular blood tests to see is there any interaction between the 2 drugs. So I don't know if I haven't really got a pointer here, but at the Marsden we're doing imatinib monotherapy run-in. So what that means is if a patient's taking part in the trial, they take imatinib for a week, had their blood test checked on imatinib to look at imatinib levels, and then they add the BKM and we do more blood tests then to just check and see what the interaction is. It's very early days, this study. It's a phase 1 study, so we can't really make any claims for the drug so far, but I think it's certainly a very interesting and promising area. I think what's very difficult for patients taking part in clinical trials is when you're taking part in the trial, we can't really offer you very much in telling you what the activity of the drug is, because often we don't know until the trial is finished and we've really pored over all the data. The third drug I wanted to talk a bit about today was masitinib, which is a drug that you may have heard about. It's been made by a smaller drug company, a French company called AB Science, and there's been some interest in masitinib potentially because it might have more activity, possibly against wild type and some other mutations of GIST compared to imatinib. And this table that you see here with IC50. What that means is how much drug do you need, oops, I'm going to attach to that. How much drug do you need to kill a GIST cell line? So the more drug you need, the less sensitive it is. So you can see with the masitinib compared to imatinib, it's more sensitive, it seems, to wild type GIST is perhaps more sensitive to masitinib than imatinib. The big caveat is cell line data doesn't always translate into patients. So while things look promising in the early stages, we can't say for sure that that's going to be the case in real life. There's been a couple of early studies with masitinib, mostly phase 2 trials, and they're quite small trials. So the ones that I've looked at have really got about 30 patients. And if you compare that to the GRID study, which was 200 patients, it's quite hard to make statistically confident statements in such a small group of patients. So I think the jury is out at the moment about Mutational. There's been 2 trials that are running. There's one which compared Mutational first line to Imatinib, and it seemed to compare favourably to Imatinib in terms of its response data, but as I said, it's a very small trial. The other one that has been interested is this second line study, comparing it to Sunitinib. But if you can see with the sort of the survival curves, there's not a huge difference. It's hard to see, but Sunitinib is yellow and Mutational is black. There isn't a huge difference in the progression-free survival there. So really, we'd like to see slightly more mature data about this drug before we make any claims for it. And ideally, you would want to test it in a larger cohort of patients. Without a doubt, we are looking for new second-line options because for many patients, Sunitinib is quite a difficult drug to tolerate with a tricky side effect profile. So I think we have to keep our mind open to all of these things. Now, this is a drug which we haven't managed to get our hands on yet at the Marsden. It's for a very, very niche area. So I'm sure we've talked a little bit about GIS mutations. There's an extremely rare GIS mutation, which is a PDGFRA mutation. And there's one particular one we're interested in, which is a D842V mutation. And we always like to check if patients have this, because if you do have this mutation, it means Imatinib and Sunitinib are both unlikely to be helpful. And so that's really critical to know before you embark on treatment. There's an ongoing trial at the moment in America at the Fox Chase Center about a drug called Canola Nib, which is made by a very small company called Arog Pharmaceuticals. And in the lab, it looks like Canola Nib is potentially very active against the D842V mutation. So they're actually taking part at a trial with patients with this mutation alone. Now, it's extremely challenging to run clinical trials in such rare tumour groups. It's difficult running trials in patients with GIST altogether. If we think about the Scandinavian study looking at the benefit of adjuvant GIST, it took them many, many years to get enough patients to take part, and that's all mutation types. If you really want to narrow it down to one tiny and very rare mutation, then it's very difficult. And it also leads into problems with trying to license the drug because we don't often have enough data. I have made contact with the company to see if they would give us some drug to use on some of our patients, but we haven't had any luck so far. But we'll keep knocking at the door because I think it'd be very interesting if we could get our hands on it. Now, this is a study one of the sort of final studies I'm talking about today, which is a study which Mark Lynch has been pioneering at the Marsden, which we're going to hope to open later this year, perhaps, maybe early next year, in combination with Novartis. It's a little bit complicated to explain, but I'm going to do my best, and please do stop me and tell me if I'm confusing you. So what it is, it's looking at involving blood tests to try and see, are we giving the right dose of Imatinib? And in particular, we're interested in something called the mean cell volume. So when you have your blood count checked, we look at your hemoglobin to see if you're anemic, we look at your white count, but we can also see what size your red cells are. So this picture is a picture of red blood cells under the microscope. And the ones with the arrows you can see are very much plumper. So they're big plump cells, and we can see that on your blood counts. Now, people noticed that patients treated with Imatinib for CML, for leukemia, often had a raised MCV. And those who did have big plump cells like that often seemed to do better on Imatinib. And so that got Ian Judson thinking, and he asked Anastasia Constantinidou, who's one of our research fellows, to look back at a group of our patients who'd had Imatinib and try and correlate changes in MCV and response to Imatinib. And it seemed to suggest, I mean, it's looking back, so it's never, you can never be absolutely sure, but it seemed to suggest that patients whose blood cells got bigger seemed to do better on Imatinib than those who didn't. And that might relate to the fact that there's different levels of Imatinib in people's bloodstream. So what we wonder is, if patients' MCV doesn't go up, would increasing the dose of Imatinib over 400 improve the outcome? So what do we know about Imatinib? Well, we know that the blood levels change over time. You probably remember people saying to you when you start Imatinib, the side effects are worse often in the first 3 to 6 months and then tend to get better. Now, one of the reasons for that is after 3 months, it's been shown that your imatinib blood levels often go down. We don't really understand why that's the case, but people seem to clear imatinib out of their body quicker after a period of time. We know if you've got very low levels of imatinib in your bloodstream that you don't have such a good outcome compared to people who've got good levels. And so what we're interested in is, can we identify those patients with low levels of blood of imatinib by looking at their MCV, and also taking blood tests to see if that correlates with the blood level being low. If that's the case, Novartis are going to hopefully provide us with drugs that we can actually escalate to 600 milligrams. Normally we're not allowed to do that. We are only allowed to use a 400 milligram dose, except in patients with the exon 9 mutation. So the trial's hoping to answer these questions. Does a short time in imatinib correlate with people who haven't got so much in their bloodstream? Does the MCV, the blood count, correlate with how much is in the plasma? And what's the effect of a dose escalation? Does putting up 600 make the blood cells look bigger and give a better result? It would be great if that were the case, because it means that we could, because we do a blood count each time you come anyway, and if we could tell by looking at the trends in your MCV what the levels are, then that's quite a simple test for us to use. Of course, it's contingent on us being able to use higher doses of imatinib, which is an ongoing battle that we have with NICE. So just coming to the end of my talk, what's the future direction of therapy in GIST? Well, it's a fascinating area, and there's a lot of research going on. There's interesting things that we're interested in are biomarkers, so looking at the blood count like we were talking about is one such example. Looking at imaging, we know sometimes CT scan doesn't tell us very much about what's happening to the GIST tumour. Sometimes the tumours get bigger, but the patients feel better, and in fact the tumour is much more necrotic. So sometimes CT doesn't give us a full answer. Maybe using PET scan or special MRI scan or ultrasound will give us more information, and perhaps we should include that in our clinical trial design. Combination treatment, so a bit like the Novartis study, using imatinib plus another drug is interesting. And the other thing about it of interest is to try and overcome imatinib resistance. So think about perhaps alternating patients between imatinib and another TKI. So have a period of time on imatinib, a period of time on another TKI. That would be very interesting. The other important thing to say is about tumour heterogeneity. So we know when we take a biopsy of GIST that what we see under the microscope might not tell you what's going on in the rest of the tumour. We know that they can do all sorts of different things. So using other blood tests like the beaming technology we mentioned might also help us. So there's certainly a lot of work to be done.